Well, let's start there. So my name is Rashi Kumar. I'm the Director of Research and Policy at Health First, and I will ask Audrey to introduce herself next. You're still on mute.
Hi there, I'm Audrey. I work at Public Health Solutions in the development and marketing team. And yeah, I'm really excited to be here and be part of this discussion.
Excellent. Next is Dr. Bean.
Susan Bean, Executive Medical Director at Health First, where my focus is partnerships for medical outcomes, and glad to be with everyone. And thanks. Thanks for
Thank
having
you.
me.
Next is Christina.
Hi, Christina Ramos-Callan, Health Management Associates, formerly of United Hospital Fund, specialist in kind of operations management and health equity, health disparities, social determinants.
Okay, thank you. Mireille.
I am Miriam McLean. I'm Managing Director for Neighborhood Health Services at Public Health Solutions.
Thank you. Heidi.
Good morning. I'm Heidi Arthur with Health Management Associates, and I do specialize in that intersection between community-based organizations and healthcare delivery systems, and work with lots of managed care companies and CBO collectives, networks, individual organizations in New York and around the country.
Okay, fantastic. Lauren.
Hi, good morning. My name is Lauren Haynes. My pronouns are she, her, hers. I am Director of Quality and Evaluation for the Division of Neighborhood Health at Public Health Solutions.
Okay, great. So PHS colleagues, is it okay to jump in 9 o'clock or should we wait 5 more? Okay. So the goal for today is to make this roadmap really relevant and actionable through all of your insights, and to clearly define the role of our sector, which is, I guess, the managed care sector, in implementing each of the roadmap's key action steps. So in this work group, we're going to review each key action step and ask a couple of questions aimed at identifying what would be required from the MCO sector for our shared plan to be successful. So there are a few guidelines for how we are going to have a constructive and productive conversation about this. Only speak to our own sector, the MCO sector, even though we may have expertise in other sectors from past experiences, only speak from our current roles perspective. Second, this isn't going to be sort of a casual conversation. It's going to be more formal. So we want to limit crosstalk. So one group member, one response. Third, we're going to focus on the question and action step at hand. We know these are all interconnected, but try to stay as focused as possible on the action step at hand. And just in terms of timing, we're going to be discussing for about 50 minutes, and we're going to leave the last 10 minutes to summarize and figure out what our key takeaways are. Any questions so far? Great. So I think
Sounds very strict.
it's very strict. And you know me, I love rules. So I think it's going to be a lot of fun. We have some great people on this call.
That's why you're a quality director in research, right?
Right, we got to stay on task here. Okay.
All right. So I'm gonna review with you right now key action 1, which is secure, diversified, flexible, and sustainable funding for a citywide community resource network. So based on our previous symposium sessions, it was clear that limiting access to community resources based on affiliation with a healthcare plan or provider would be an impediment to health equity because there are many people who aren't connected to insurance. Based on these conditions, the roadmap recommends a diverse funding model and infrastructure that allows accessibility for all New Yorkers. So I'm gonna pause and let you just read the slide to internalize all that information.
Secure, diversified, flexible, and sustainable funding for a citywide community resource network.
So the three bullets so far are raise startup capital from government, foundations, corporations, healthcare stakeholders, and private individuals.
I guess from the managed care perspective, what would the CRN do?
So the question we're supposed to answer first, based on key action 1, is what do we see as our sector's role in financing a community resource network?
Okay. Well, that's actually pretty easy. We are, as payers, we reimburse. I mean, I think, I don't think that, yeah, I think we're bullet point 3, negotiate payment structures to ensure equity. That absolutely. Um, Across community-based organization, yeah, I don't think we should link it only to Medicaid. I absolutely, but I do think that, our role is bullet point 3. How do others feel?
I would say that the question here very closely reminds me of the accountable entity model that Rhode Island is using under its waiver
Mhm.
to develop what I'll call for shorthand wellness trusts or wellness funds that MCOs kind of each of the MCOs in the market throw in a pool of funding and then create a capital stack for which they will have basically like a quasi accountable health community, but from the perspective of attribution to the MCO. So I would think about that model as a correlate for the frame of this discussion. Happy to drop a resource in the chat for that. There's
Yeah,
a
let's
good
do it.
article from Nashby.
Yeah,
Yeah.
please. Thank you. That would be helpful to me.
Okay, let's see.
Bullet point 1 or 2?
Yeah, that's for the capital, and that's for the capital, and it would be like a waiver amendment proposal kind of thing. So it kind of touches 1 on 2, right? Because
Mhm.
the structure of it is under the Rhode Island waiver, so it would be it would, you would look at it as here's a way to fund it, right? But you might need to make some regulatory changes that would be possible under the waiver as a pilot to implement it.
I mean, the tricky part about that is where do the MCOs get the funds? Do the funds come from the state to the MCO and then the MCO to the wellness fund?
Um, in some cases, yes. In other cases, there are some MCOs that use their community foundations to seed
Okay.
Okay.
the funding pool. I'm gonna drop it in the. I'm not really sure how Ring works. I'm gonna drop it into the chat to Rashi and see if she can share it with everybody else in the group so that it doesn't go to the whole of the meeting.
Oh, that's smart.
Okay.
Okay. Heidi, anything to add so far?
Yeah, I would just, I know that traditionally the managed care role has been so transactional and rate and reimbursement focused, but increasingly states are looking to MCOs to collaborate with one another and begin, contributing to community investments in a more collective manner. And I think this is one area where, there could be a need for real collective sharing of those dollars toward the goal of really knitting together something that everybody can use for those closed loop referrals and for those sort of cross system connections. So yeah, I do think it represents sort of that departure, that population health kind of next generation of the MCO's role as a payer within a more integrated and interconnected clinical delivery system. It's what we're seeing across the country is sort of like shaking up that sort of, we stay in our lane vision and really getting MCOs. I'm thinking about California right now, MCOs are starting to come together and really sort of plan shared cross institutional policies, tools, resources, really kind of standardizing everything and beginning to look to hubs for, sort of streamlined contracting and shared, sort of processes and approaches to community resource networks. And those may not be the same across the state. They will not be the same across the state because of health information exchanges being different and, all sorts of glitches and barriers and, sort of that whole arena being its own mishigas. But the piece around MCO participation is going to need to be really collaborative.
Heidi
Mhm.
and Christina, how does that work? Because generally that's sort of a role that not-for-profits pay. It's part of our play. It's part of our mission and our DNA. Does that work in a state like New York where we have so many commercial plans that are maybe driven a little bit more by shareholders than you know um, community benefit?
It's a good point. It's a good point. And I think that's why it has to really come from the state. This
Mhm,
can't be, oh, let's just depend on the kindness of these corporations to really chip in and do their part. It really does have to be a state mandate.
mhm,
Yeah.
mhm,
Christina, would you agree?
Mhm. Yeah,
mhm.
I would agree. And wait, am I still on mute?
No,
Yeah,
you're
I
not.
would, no, I would agree. And I would say that for states that have a competitive procurement, it's a little easier because the markets are more narrow.
Mhm.
So you just have a better sense of the kind of, you just have a more focused sense of like population health management in those areas. Whereas when you have just these non-compete states that you can't really get a sense for how do we do initiatives that are going to be really meaningful because the market is so fragmented and everyone's doing their own thing. It's a little bit Wild West.
I mean, Health First actually tried to do this around maternal health, right, Rashi? We pulled all of the MCLs. They were all willing to come, not for profit, for profit, didn't matter. They rallied around the health commissioners, um, you know, um, who was Mary Bassett at the time, call for addressing equity and combating racism. And it can happen. Um, I think that one of the ideas on the paper was on the table was something like this, where we would create a wellness point, sort of a wellness fund. Um, the issue around it though is without the state specifically, it's not just a mandate, but it's sort of understanding the funding mechanism. Our dollars are pretty closely accounted for. I think um, depends on what it takes for the startup capital. And what I have seen, um, and what wasn't funded necessarily through DISRIP was, large. I mean, DISRIP, and I mean, Heidi, you know this well, DISRIP really only funded the planning. It didn't actually ever get to the startup capital. So, I mean, go ahead, Christina, you want to give feedback on that? Yeah.
I'm just,
Yeah. Yeah.
yeah.
So I think we have to include that in our comments that it's not that MCOs are unwilling to do it, but the state has to help us connect it to outcomes that they're looking for. In other words, quality outcomes. We still have to stay true to our mission, which is not driven by social, curing social ills and needs and addressing social needs. Our mission really is around improving health outcomes. So, I like the concept of the wellness, that this community resource network that we're talking about here is a wellness network that focuses on improving health outcomes and medical outcomes for New Yorkers of all ages. Now it aligns with where an MCO is coming from because at the end of the day, we're performance driven also. Um, and our performance is really driven by medical outcomes, whether it's quality or improving health status so that you know, we are producing positive results for the state, for a Medicaid plan, et cetera.
Yeah, great. I think that brings us really nicely to our second question is what sources of funding would support both startup and ongoing costs of a citywide community resource network that our sector is uniquely qualified to tap into?
So about that, I have a question that the previous conversations made me think about, and that could help us think about that question. And it was thinking about value-based payment arrangements and that whole notion that you don't really need to generate new funding because you're saving so much by investing into community resource network. You have so much saving on avoided hospitalizations, readmissions, and so on, that there's not really any need for new money. You just need to be able to capture those savings. And I wonder, disrupts, the most recent report about disrupts evaluation tended to indicate that it had been successful. But is it on the aggregate, it's possible to measure, but when it comes to apportioning which actions led to which saving, it becomes, in the end, from the social determinants of health perspective, I think the field in New York hasn't really been successful in creating value-based payment arrangements that were tied to social determinants of health. I wonder if in Rhode Island and in California, they've incorporated this idea of value-based payment and savings into their funding model, or if they said, no, actually, we are doing it in the aggregate. We invest here, there's going to be some savings there, but we don't try to connect them. And what would we need to do that to be able to fund this in a sustainable way?
Well, Murray, I have strong feelings about this, so I'm going to speak softly. Uh, we've been at this for trying to figure out how to have a community. We call it a partner network. Partners are really partners with our PCPs. And what we have found is that if we isolate the social needs from the PCP needs, we don't see a return on investment. So we have been successful in convincing our senior leadership to invest in community partners because we don't require them to have an ROI. I mean, Heidi, you know this too, because
Yeah,
you've heard
yeah,
me speak about it.
The
Christina?
ROI is really hard to pin down and to attribute back to a specific investment or a specific intervention, and that's why it does need to be kind of an upfront, sort of shared, collective. We all agree that this has value,
That's right.
and then the sort of track back to how do we relate the savings needs to be in those interventions that really kind of get in and really specifically assure that there's connectivity between those partners, those community resources, and at what level and to what degree, and perhaps startup costs, and then a rate that's equitable around kind of what is it that they're meant to be delivering. Most states that we're seeing come out with procurements these days are integrating an expectation around value-based contracting, value-based payments. They're not necessarily prescriptive at all in terms of what needs to be inclusive or how to go about doing that. And I think the challenge that a lot of MCOs face is it's hard enough to get that going on with the providers who have standardized services and standardized rates for the Medicaid, sort of requirements. It gets really complicated when you sort of think like, okay, that's how I will do that within this network. Now let me just do those same things with my same infrastructure over here at these community-based organizations. And then what we're seeing in California right now is they typically go to the usual suspects, the larger community-based organizations, and everybody gets upset because in the grassroots, the smaller, really well-connected organizations get left behind because they don't have any infrastructure that even, even begins to approximate what the usual network sort of Medicaid vendors can offer. And then value-based contracting is like, we're in a whole new world of helping those organizations begin to play. And I think that's where, the Communities Together for Health Equity really tried to sort of do some level setting with some of those entities and create an infrastructure. And my sense is that social determinant of health networks are intended to be that kind of like plug-in. And if with the waiver, we're able to build those hub plugins for MCOs, then it becomes a little easier. Susan, I don't know if you agree. It might be.
I do. I definitely do. No, yes, I think we agree with the concept, and I feel like we're beginning to explore that. I think it won't be one network. I just think that New York City is too geographically diverse for it to be one. But I think that there will be some major ones, like if you're separated by water and you have to take a bridge over to where you live in New York City, you may be different than the rest of the mainland, so I don't want to, so I definitely agree with this concept. I just think that the fact of the matter is, the pandemic showed us this, that when people are not sitting in provider offices, healthcare is still happening or healthcare is not happening. And putting resources in the community makes so much sense. I mean, I just think that Rand actually just published a new paper. I shared it with my team. I don't know, Rashi, if you want to share it with this team. Redefining social determinants and doing what I ask, which is to talk about social need. So something I've learned from the FNS study by PHS is that they were able to see in real, in the evaluation, acute social need is often more of a determinant of health than socially determined health, like where I live and my exposures, et cetera. Because people are not always stationary in those, settings. So I think that we are entering a new phase, Heidi, where what you're saying becomes even more true, that we need to be able to have networks that deal with social need, which is something like a pandemic, mobilization. And then we need networks that are expert at enduring social determinants, as well. Does that make sense? And maybe, Rashi, can you pick up that RAND study out of Teams? Or else I can. Don't worry, I'll put it in chat to you.
Okay. Is it multiple networks, or is it sort of like a standard for how to, and then it's within that sort of framework, targeted issues are contracted to be addressed by sub networks? Because I get worried about organizations trying to do multi-borough services and having to not only deal with the infrastructure for one arrangement, but then having to do wholly different things. So I'm thinking about the Pathways Hub model as such a great way for an organization to say, here's how we're doing it. Now we're going to do this with everybody. We can contract differently for different populations. We can do it for different services, but there's a methodology that's sort of standardized. And similarly for the Community Resource Network, is it going to be Unite Us? Is it going to be the PHS, sort of methodology? And if so, can it not then be sort of customized based on those social needs for different populations, for different needs, and differently in each borough, I guess, is, sort of like, can we come to agreement about what the requisites are, build something that can then be utilized more flexibly?
I think we've actually migrated really nicely to Key Action 2, so we can head straight there. So Key Action 2 is create an administrative backbone and infrastructure to support and facilitate the work of CBOs at all levels of capacity. And the question at hand is, what do we view as our sector's role in any, if any, in building CBO capacity? What would you do if you could? And what would you prefer to be handled by a network administrator?
Mhm. From the MCO perspective, I'll start again. Oh, well, I don't have to. Let me punt that. I'm
Right.
not starting.
I would, viewing how some of these kind of administrative backbone hub and spoke model type organizations are or have been organized in New York and elsewhere, and kind of tying this back to what is the potential funding, right? Because the backbone would need to be funded. I can envision a situation where a number of MCOs buy in to a administrative backbone that conducts the capacity building and the technical assistance in order to support and maintain a network from which they can purchase services, rather than having to build out that capacity within each of their organizations. So I would, thinking of it like a membership model where we invest some funding in an organization that will do, like a trade association or some kind of IPA that does the technical assistance to maintain people's professional development, that helps them stay up with standards, that makes sure that quality metrics are done, that does data aggregation, and is able to both report on regional and by payer outcomes, but then can also then attribute back which payers are doing a better job with outcomes and help make that data presentation very, very clear, right? I can't see a situation where an MCO is going to be buying one kind of community health worker certification service in Bayswater and Rockaway versus something else in Pelham in the Bronx versus whatever's happening in Flatbush. But I can see them investing, $150,000 in helping to fund a couple of FTEs that conduct the technical assistance to make those things happen in multiple boroughs. Right? Just what can we do to encourage the MCOs to stop building things themselves and start buying things so that you don't have an army of care coordinators from all different aspects of the care continuum. And then someone on the patient side has to figure out, well, who's calling me for what now?
Mhm. Mhm.
Right? So a lot of this discussion has to think
The
about what
state,
is the patient
the state would have
experience.
to incent us to do that, right? I think the state would have to place value on that, this community-centric um, version. And then however, the same time, we don't want to go back to that sort of community dispersed case management. We already have health homes. So the state is invested in health homes. We need to, in my view, have the state invest in the navigators, not put them under health homes, but just not everyone's eligible for a health home. But this kind of care navigation process, we're calling it now, that reaches people where they are, whether it's in their doctor's office or at home or anywhere in between, their bank, their Starbucks, I don't know.
Is there a way to think about the impact of all of this kind of administrative building and planning from the perspective of how, like, what is the patient experience of all of this? How does this all trickle down to what a patient is experiencing or a covered entity is experiencing? And then from there, like, always start with the outcome in mind, right? So what do we want the
The-
idealized experience for the member to be?
I
And then how does that flow back up into what the planning has to be?
I think it has to be, from our perspective, non-clinical. And I think, although there's a medical part of this, which is to get you into the health system that's going to make your health outcomes work. But what I love about the human services industry is this whole, it's all about you person concept. And that's what, MCOs are unfortunately very much about what we have to achieve because that's how we're paid. But I think that adding this human services aspect means that the member can say, I'm just tired of being pounded about what I need to do. I need someone to help me. So that's my personal health first feeling.
I think it's very interesting way of framing key action number 2 to make it about the idealized, MCO member experience and look at it this way so that then the MCOs would say, we'll come together and we are going to purchase the product, which is the administrative backbone that's going to deliver ultimately the best experience for our members in terms of getting the connections to these services. But, and you alluded to it, Christina, MCOs they've internalized this function. And from where I was sitting, it felt like, well, that's also a really excellent member experience is how various MCOs hope to differentiate themselves from their competitors. And New York is a competitive market for managed care organizations. So if we were to take that away from the MCOs and say, no, actually, it's all going to be standardized and it's going to be a different entity who's doing it, then where will they be able to say, is it going to be the content of the, purely the content of the benefits? Like, you can have one session with an acupuncturist through this plan. And I think
Right.
if we want the administrative backbone to be, there needs to have buy-in from MCOs to say, yes, that's great. Let's put that off on someone else. But to have this buy-in, what are
Right.
the barriers now?
It sounds like one of the things that the MCOs can contribute is innovation, right? In terms of how to reach people and ways that are working. And that innovation should be part of the contribution to this network. That's what I'm hearing behind what you all have just said.
Right. The MCOs still have their kind of captive market of beneficiaries. The challenge is demonstrating connection and equitable access to the services that are available in the market from the CBOs, right? So there's New York City has an equity problem around access to human services. It just does, right? So how do you solve for that in a way that, Heidi knows I like my colloquialisms and analogies, but like rising tide lifts all boats, right? So how does the MCO market as a cost of doing business in New York contribute to the capacity development and the equitable distribution of CBO services in such a way that they will benefit from them, right? Because the MCO will benefit from an equitably distributed and strong CBO market in the state or in the city. So what is the investment required to do that? I would think of it as investing in the professional development of on a personal level. I'm going to invest in my education, or I'm going to invest in the structure and supports that are going to help me succeed as a professional, right? So I'm going to make those targeted and, take a risk on doing whatever thing, pursuing a certificate, going to school, whatever have you. How do you think about that in terms of, if I want to do this with this market, there are things in this market that could work better, right? But they need to work better equitably for everybody, not just for my big B population.
If I remember when DSRIP rolled out, CBOs all of a sudden do VBP contracting, if anybody remembers that whole thing. And I think that this startup funding has to, I think that CBOs are excellent because they are who they are. They think differently, talk differently, and relate to people on a personal level. So I think that we don't want to lose that, you know, but I do think that the ability to receive work from an MCO is what our charge is here, because there are certain kinds of platforms that do not allow MCOs to actually give work at a population level. So I think the administrative backbone, whatever the regional lead entity is, has to be able to support these CBOs in staying who they are, don't go changing just to please MCOs, but at the same time, um, help them create the mindset that you're going to get a list of members. You're not going to get one at a time. You're going to get a list. You're going to have requirements. It's going to be timely. You're going to have trust our technology, you know, and then train on conditions or, you know, or working collaboratively, you know, and et cetera. Christina, I think that's the main thing, is that I don't want CBOs to change. I want them to be who they are because they're community people helping other community people. But I do think that MCOs think at population levels, and they have to make that work for individuals.
Yeah, ideally, this is a structure that really helps to balance the lift. You know, sort of
Yes.
like really helps to like take that burden off of small CBOs and leverage large CBO capacity so that all of the CBOs get to be in the game. And it, you know, that I'm thinking, Susan, of like just the work that your team has put in around credentialing support, around really like leading CBOs to like, here's the structure to tell us what you're going to do. You know, like here's concretely what we are looking for, and educating them about what the need is so that they can begin to conceive of how their that fits into your this, right? And that having an infrastructure that systematically offers that sort of as a standard kind of
Yeah.
plug-in, I think is what we're really needing. Is like, what's in it for me as a CBO, give me the value, and then make it possible administratively. And having MCOs kind of contribute toward that. And then what you do with the contracts can be negotiated with that entity. Do you agree?
I moved
that's
us to key action 3 because what you're talking about, Heidi, I think ties in with that. And hopefully even answers the questions. I'm just keeping an eye on the time.
Thank you.
So you were talking about not just the backbone organizations role with MCOs, but the backbone organizations being the home where community engagement could take place if it's designed that way. What was the question for that particular?
What is your sector's current approach to engaging communities in your work?
Okay, so we've talked about that quite a bit. That's great.
So the second question is, how would you anticipate your sector contributing to the goal of including the intended beneficiaries of a community resource network in its planning, design, and implementation evaluation?
Just call PHS. Or Heidi.
It's a Heidi, I don't know about Metro Plus. It's a pity they're not here, but they have brick and mortar community hub now, and we just started co-located SNAP enrollers in those hubs. So I don't have it's a few weeks during a pandemic. I don't have visibility about what's going on, but talking about internalizing their function, it would be cool if this was a home for more than one MCO, and there could be any MCO members going there.
Yeah, I think, Heidi and the Pathways Hub model, the Pathways model, I think has finally, it's its time. The more I'm thinking about it, however, PHS offers a different kind of engagement strategy that you're in the midst, and what do you need? So I think it's sort of pointing to the neighborhood or the providers or region or population, and co-designing sort of what the, how best to address the need.
Mhm.
That's what we've learned.
The PICHC, am I saying that right, for pregnant women? And yeah, is that the name of the model?
They
The
say
state has-
pitch now, like the
Oh, do
perinatal
they? Oh,
infant
nice.
pitch. Yeah.
Cute. I'm glad, because I never could get all those acronym that acronym quite right. But that model, the state really did lay out a structure for stakeholder engagement, multi-level stakeholder engagement. And what we tried to do in Central Brooklyn was not reinvent the wheel. And so I think similarly for this kind of engagement, ideally MCOs don't each go out and, like we do stakeholder advisory groups, we're all going to do it. Hey, join 9 stakeholder advisory groups. Like ideally they're sort of like their existing networks, their existing efforts. And there should be something that is really structured at the grassroots level to engage community in a more comprehensive way.
Okay, should we move on to 4? Okay, great. Key action 4, employ regulatory methods and advance policy and practice that ensures a favorable technology ecosystem. And our question at hand is, what can our sector do specifically to minimize the potential access barriers created by the proprietary nature of the technology ecosystem?
Well, the issue here is that one size doesn't fit all, and CBOs don't have the funding to make their multiple technology requirements. I think funders have to be more flexible and, build around the CBOs rather than building upon the CBOs. And, I think that part of the startup is, creating population health platforms that CBOs, the regional group, can use. And then those regions tie into the community information exchange. I mean, I just think that it's too hard and it'll take too long if we say, okay, you can only work with NowPow. I'm making that up. I think that there are, acute needs and social needs, have to be able to, the regional group has to be able to adapt to that. And they have to plug into MCOs. I mean, I feel like, if we, from our industry, it's very hard if we have to add work to make this happen. A lot of times it won't work. So that's what I've learned over time.
So when you receive a piece of direct mail, that piece of mail has to be designed within certain specifications
Mm-hmm.
so that it can be processed appropriately by the post office. And there is a person at the post office that you can call or email, and say to them, I am designing this piece of direct mail. Can you help me understand the specifications so that it will be processed appropriately by your system? And that is a service that the post office has invested in so that they reduce the number of errors and returned mail and everything else. So, you know, there's literally a person. I've done this before. There was a guy who emailed me back and said, you put this in the wrong place, but I moved it for you and now it's fine. Right? So is there a way to get regulatory structure around, if your system says this, then it needs to map correctly to this field over here in this? And it's like a key, like a translator, like a I forget, a cipher, right? So that each CBO, whatever system that they're using, has to understand that the system that they use has to function as a management of information system, and that they can do whatever they need to do on their side, but they have to spit stuff out that can get uploaded and used by other parties so that we can aggregate data, run quality analytics. Like, if you want to participate in this system, you have to know what the cipher is so that everybody can understand, right? So is there a function in that administrative backbone entity for TA that helps CBOs figure out what is the cipher, how do we code our information so that we can operate within whatever capacity we can operate on our side, but we understand what needs to get flown, what needs to flow up out of our organization, so that you don't have to say to them, you must use NowPow. You can use what you're using, but you need to understand how to code that information so that it can go into an exchange.
I like it. I like that.
Right? And that's one of the functions of the capacity building and technical assistance, right? Because that also helps you level set across an industry. When you see that the demand for that capacity development is so great across all of these different CBOs, then you start getting the leadership talking to each other and saying, this is crazy. We're all trying to translate different things to each other. We can't share information easily. And then people start to coalesce around an idea naturally. But in the interim, getting people to just do the baseline understanding of what is the information that is required to populate these exchanges, and how do we develop that technical capacity in-house so that everybody always understands what the basic language is, whether they have some kind of dialect for it in their own organization or not.
Sounds right. How to do that, I don't know, but it sounds right.
I mean, it's, for some places, it's going to be as simple as, like, you have an Excel spreadsheet and I'm going to show you how to code your information from one place to another.
Yeah, if they
It'll
have
be
an Excel
it'll be
spreadsheet,
hand-holding.
they won't work with Health First.
Right.
That's the problem.
Right.
Literally, they will not work with Health First.
Right.
Because I think along with all of these new partners we're having, the one thing that we do train them on is what HIPAA privacy and security really means.
Right.
And Excel spreadsheets are
Not it.
So they're not gonna, unless the resource network can, they have to bridge that. We have to stop sending Excel spreadsheets.
Yeah, and I know that I worked with one organization who is a hub on behalf of multiple community-based organizations. And essentially, they went to the MCO with the most strident standards. They set that as their bar, and then they raised all of those CBOs to that level, and kind of inculcated it as, this is now how practice happens, and this is the standard, and everybody kind of goes to that level. And that was just a really quick way to say, all right, this is what your system needs to be able to do, this is how you need to be able to interact. And then there was support targeted where there was necessary, sort of gap filling, but that set the standard. And I think in New York, we can decide, what are the requirements. Now, everybody, these are the requirements, to Christina's point. This is the sheet. once and for all, this is what it's got to look like. I think that would be such an expediter. Just
My one worry about that in New York State, Heidi, is we're still so like not up to date in terms of what these organizations do. So we still think that we need to know that you touch the member 12 times or you touch the member 2 times. And then we need to know, and you worked with them on housing, and but you're doing coaching, you're doing housing, you took them to a doctor's appointment on the same day. So we have a very narrow view of what social human services organizations do. And therefore, we have to just be careful that managed care doesn't overprescribe to the organizations what they need to report on. Then I think,
yeah. If it's regulatory and it's related to maybe tiers of engagement, so one tier might be very low threshold, like you just need to know who's the payer, person's name, like, and there might be a low threshold level of service and what the requirements are there versus something that is, to your point, more service specific. And then what does that service include? I think, and that's where it gets into what are you paying for versus what are the requirements to play.
Right.
And the requirements to play should be regulatorily driven and legally based. And I think where we get into a lot of trouble is people's lawyers have overreached and created this like super robust and overly conservative threshold for participating. And I think if we can just sort of agree what is the least restrictive, but most, where is the bar, and get everybody to that, then the services piece that you're speaking to could follow along.
And I would add the bar to the level of documentation that's required. I think Dr. Bin was talking about that. It's true that over documenting is not useful, but if it's a requirement for payments, it will happen. It's not effective.
Yeah.
There are really conflicting injunctions there.
I was going to add that some of that over documentation behavior on the part of some organizations is really legacy from the documentation requirements for payment from, for example, senior centers, right? Every time somebody comes in for a meal, there's a click on a button so that you can document it for your Title III funding, right? So, or for your Department of Agriculture funding, right? Because that's what funds the meal program. So you end up with, we had 500 engagements. And it's like, no, you didn't have 500 engagements. You gave out 500 plates of food this week. That's not 500 engagements, right? So there's a culture shift in just the language of what is an engagement and there's a culture shift of what is episodic care.